Thank you for the opportunity to speak. So I'm going to be talking today about use of a structured teaching observation tool and video review and how we found that it improved resident teaching skills. I have nothing to disclose. So we'll discuss the structure and content of existing resident as teacher curricula that are published in the literature, and as well as show how you can utilize a structured teaching observation tool that we developed here to assess resident teaching skills, or any teaching skills. So why resident as teacher? So I think, as we all know, residents play a key role in teaching medical students and their peers. Back in the 1980s, so who knows how that's changed now with the EMR and whatnot, but residents were found to spend at least 20% of their time teaching students. And it's been shown that teaching improves not only knowledge acquisition more than self-study or attending a lecture. Teaching increases resident job satisfaction, and as with many things, it's a regulatory requirement. So both the ACGME and the LCME require that residents are provided with skill development related to their roles as educators. They not only teach students, but they teach their peers, they teach other members of the team, and they teach their patients as well. So in terms of the evolution of resident as teacher curricula in the literature, the first resident as teacher programs that do it effectively call it RAT. Other people find that weird, but we call it RAT. So it was first described in the 60s and 70s. By the early 90s, it kind of really gained momentum in the 80s and 90s. About 20% of medicine programs had resident as teacher curricula. By the 2000s, half of primary care residency programs, this included medicine, peds, OB, and family medicine, had some curricula in place. And in the 2010s, now we're at 60% of emergency medicine programs, and 87% of pediatric residency programs now have curricula in place. Surgical programs do have resident as teacher curricula, and many of their publications are focused on teaching around procedural skills. It's just that many of these came from surveys of program directors, and I didn't see any from surgical fields. But surgical fields are doing resident as teacher as well. So in terms of how are they structured, so nowadays most programs have curricula in place, but they're often limited in scope. The average over the course of training is about 11 hours. In a survey of pediatric residency programs, 75% provided 15 hours or less. And you can see here that the most common format for instruction is in the form of a lecture, although workshops certainly do exist as well. And it was nice to see that direct observation was definitely present in a fair number of programs. So in terms of the consumer approach to what makes a great resident as teacher, you did a survey of students saying, well, okay, what do you look for in a great teacher? And you can see here what the students like to see is what's going to help them kind of retain their knowledge, what's clinically relevant. I was interested that in terms of feedback and either providing and asking for feedback that wasn't necessarily high up on the scale of things students wanted to see. They wanted clinically relevant examples. They wanted people to repeat the points, summarize, show techniques, use of lectures in the form of, a breakout session or a PowerPoint. The PowerPoint lecture that everyone feels like they need to give was not necessarily high up there. In the literature, what do people include in their curricula? Things like feedback, doing case-based teaching, teaching inpatient, which is obviously where the residents spend most of their time teaching the students, either at the bedside or on rounds. Obviously, evaluation, how do you teach evidence-based medicine? Principles of adult learning or learning theory is generally included in most curricula. The 1-minute preceptor is the most common, actually, that's included in there, and that includes, for those of you that have heard of it, the micro skills of teaching, which is get a commitment. What do you think is going on? why do you think that's going on, getting a sense of diagnosing your learner, then teaching rules, giving pearls, and then reinforcing what is done right, but then also correcting mistakes. It's known as the 1-minute preceptor because you can do all of those things in a short amount of time. It doesn't require you to have a 60-slide deck PowerPoint presentation. It doesn't require you to carve out time. You can do it anytime. You can do it on rounds. You can do it at the bedside. You can do it in the clinic. You can do it teaching a didactic session. So these are very simple ways to approach clinically relevant teaching, and it allows the learner to diagnose the patient, but then it also allows you to diagnose your learner to see how are they thinking, what is their thinking process, is it a knowledge gap, is it a clinical reasoning gap, and you really get a sense as to how they're thinking. And I joke on rounds, I love to play guess what I'm thinking, and ask that question that then they look at you and it's like, no, but you really get a sense as to how people are thinking by using questioning as a teaching tool. This is Rena's work here, and I love this. I thought this was such an interesting study. This was a multi-institutional qualitative study really exploring what teaching strategies are used by excellent teachers asking students. And as you can see here, in terms of the most frequently identified method, it was role modeling. Obviously, finding teachable moments, taking time to teach, having enthusiasm to teach, developing a great learning climate, a safe learning climate is very important, and then providing experiential learning opportunities, all very important things. But role modeling was actually the dominant theme, and this is historically not addressed in resident as teacher curricula. We do not really specifically teach our residents how to be role models, although I think we can all agree it's incredibly important. So just a quick review before I go into how resident as teacher programs are evaluated. This is Kirkpatrick's model of program evaluation. And when we talk about curricula, we often think of it in what we call KSA, or knowledge, skills, and attitudes. The level 1, which is learner confidence and satisfaction, is the most commonly done because it's actually the easiest to do. It's important to do. You want your learners to feel confident after having your intervention or enjoy the teaching that you did, but it's considered the lowest level. You then want to make sure they've acquired the knowledge, skills, and attitudes, and how do you identify that? And then once they've acquired it, how are they actually utilizing it in their workspace, either while teaching or while taking care of patients? And then the highest level, level 4, is the hardest, and that's really an impact on the outcomes of patients or students or the organization. This is the hardest to actually show. So what is in the literature? The most common form of assessment of resident as teacher is in the form of learner comfort or satisfaction. This is from a survey of pediatric resident program directors. And you can see here that a third are pre and post satisfaction data, or a survey of the curricula. Having said that, direct observation thankfully is there, because to actually see what people are doing in terms of teaching, we do need to be watching them. That obviously is time and resource intensive. And how do you actually then do it? In what format are you observing? So how do you then move beyond learner satisfaction to higher levels of Kirkpatrick's? And certainly the objective structured teaching encounter is one that's widely published in the literature. It was first described in 1992 and is modeled after the OSTE, so the objective structured clinical encounter, which is basically the standardized patients that is now used broadly to assess clinical skills as high as step 2, for example. With an OSTE, you take a standardized learner in place of a patient, and then the standardized learner provides the feedback, or a faculty member watches the encounter and provides that feedback. As you can imagine, this is time and resource intensive to train these standardized learners. You can use medical students as standardized learners, but to some degree, any standardized patient or learner needs to be trained. And then how do you observe? Do you videotape? In what format? And I think, to me, it's not done while you're teaching in real time. So what are you capturing in terms of how they actually teach in the moment? In terms of a systematic review of OSTEs in the literature, most of the studies that are looking at OSTEs are looking to determine the reliability, which they have found, yes, and validity, not as clear, of an OSTE checklist. So people are creating checklists and then using the OSTE to assess that, not necessarily been able to show that using an OSTE improves teaching skills. This is a project out of Cincinnati Children's that was a prospective study of interns on a hospital medicine rotation who did a videotaped teaching encounter with a simulated third-year student. The intervention group got a 1-hour resident as teacher curriculum, and then they taught again. And this is just to really show you an example of what an OSTE looks like. So it is objective, so it's skills that are done or not done. And this looked at, establishing learning objectives, assessing the level of the learner, creating the learning climate. And what they found was that OSTE scores increased for both groups. So for the group that did or didn't have the curricula, increased, and there was no significant difference between the groups. So what improved their teaching skills? Was it the resident as teacher curricula? Was it the teaching? Probably a combination of both, and we need to be doing a combination of both. So a structured clinical observation. So a structured clinical observation is a known method to teach clinical skills with limited time and resources. So a structured clinical observation is sort of similar to an OSTE, except it's not standardized, and has been shown that you can use it to teach clinical skills with limited time, limited resources, which we have. And so this project was to develop methodology to teach clinical skills, and what they did was they created this structured clinical observation form that was meant to document process over content. So they were watching students perform a clinical encounter, and it wasn't that did they do all the steps correctly, but did they wash their hands? Did they ask open-ended questions? Did they use jargon? So it could be used in a broad number of encounters, and they were designed to be short observations, so 5 minutes. And they were able to complete a number of observations in 63 students, and it was highly rated by students and faculty. The intention was for use as formative feedback. It wasn't to say whether or not they were competent or not competent in clinical skills. It was meant to really guide their development. And so people are using these, at least in pediatrics. I don't know, medicine, have you heard of this? People are using this in pediatrics, and so as I developed my project, the concept of a structured teaching observation tool was suggested, and that certainly has not been previously described. So what are limitations in the curricula? The publications that are in the curricula that are limited and lack the details needed to reproduce them. So there's 2 big reviews of literature, big meaning the ones that are out there, and this included, one was 24 studies and one was 29 that met inclusion criteria. Both were in 2009. So not a ton of publications out there. 50% of these publications were descriptive and lacked any outcome measurement. The most common intervention was the 1-minute preceptor. Most were uncontrolled and non-randomized. As you can imagine, that's not a surprise. But even those that were randomized had risk of bias. Either they had incomplete data collection, they had selective outcome data reporting, or as you can imagine, it's hard to know sometimes. It's easy to know who had your intervention. The most recent review had 39 articles that met criteria, and you can see here 25% did meet the highest level of Kirkpatrick score, but basically were only one of the articles had both the curricular content and evaluation methods that would allow other programs to reproduce. And this was, the group of authors went through these 39 articles, and they met consensus as to what met the definition for not reproducible, partially reproducible, and fully reproducible. And then one author went through all of the studies and then characterized them. And so you can see here that it's hard to then take, if you don't have a resident teacher curriculum and you want to take what's in the literature, you have limited options for what's out there to adapt or adopt at your home institution. So what do we do here at Mount Sinai? There's two of us that kind of, Blair Hammond and I co-directed the clerkship and the sub-I, and we really have been responsible for executing most of the resident teacher content in the residency program here. We both completed the IME's Teach the Teacher program back a number of years ago now. That is the basis for our resident as teacher program here at Mount Sinai. We have a longitudinal approach to development, so we do workshops in the PGY 1 and 2 year. The PGY 2 year is a number of hours. The PGY 1 year has been usually about an hour or so. And we focus on, in the workshops, principles of adult learning, setting goals, how do you develop a learning climate, what are the micro skills, how do you use questioning as a teaching tool, and then how do you give feedback? How do you solicit feedback and then give feedback? It then culminates in a 4-week teaching rotation in the PGY 3 year, where they really teach in a variety of settings with learners of different levels. We revised the curriculum probably 5 years ago now, and as we were getting feedback on it, one of the big themes that came out was that the residents were like, we didn't all get the opportunity to participate in teaching at ASM, and we loved it. And so could we figure out a way so that everyone had that opportunity? So now everyone has the opportunity to participate in ASM. Then obviously they're heavily involved with the 3rd and the 4th years on the clerkship and the sub-I. For example, one of the things that we have them do with the clerkship is they give feedback on a progress note with the student. So the student gets feedback on their progress note, and then the student does it again. We started that this year, and that's actually a part of their grade as well. So you have someone actually looking at the student's note, getting feedback and doing it again, and it gives the resident the opportunity to do some teaching around that patient, give feedback, and then also participate in evaluation. One of their main responsibilities, not main, but one of their consistent responsibilities in the clerkship is they lead a facilitated case discussion here of jaundice 2 to 3 times over the course of the rotation. Students complete the jaundice case usually when they're on their well baby rotation, which is 1 week. And so a teaching resident over the course of 4 weeks might teach that 2 to 3 times depending on the schedule. And they also obviously teach their peers. So as we were revising our curriculum, we really recognized that we really didn't have a ton of assessment within our curriculum, and we looked at what different checklists were out there. The available checklists that we were kind of handing out were really, really long. They were either 2 pages long, or they were focused very on subjective skills. Are you an excellent teacher? Are you an outstanding teacher? This is one that's published as Clinical Teaching Effectiveness Instrument that's useful and assessed to be reliable, had content and criterion validity, but had descriptions such as like mediocre and superb. And I didn't necessarily want to assess whether or not my resident was a mediocre or a superb teacher. And so we decided to review the literature, and we developed our own checklist. We obviously wanted to assess skills that were included in our curriculum, and wanted to focus on objective measures that were either done or not done, with the philosophy that you really actually need to acquire skills before you master them. Why I don't want to focus on making you an outstanding teacher if you don't actually have the skills to do so. I'm proficient at intubating because I've intubated hundreds of infants now, but it took me doing that a number of times before I became proficient, right? So that's an easy skills-based one. And you can imagine with teaching, we all have our own teaching styles, and you're teaching in different formats. And so we really wanted to focus on that first. So we hypothesized that using video review and structured feedback using the checklist would assess the teaching skills in our pediatric residents during their teaching rotation. Again, we wanted to focus on skill acquisition before mastery. And I actually developed the idea after participating as a faculty member in our Compass review. So the review that we do for the end of second year students that go through standardized patients, we observe them. And for students who have struggled a bit, we actually watch their videos, we identify what areas need to improve, and the students watch their videos. And what I found was that when the students watched their videos, that was just an incredibly powerful moment for them, really seeing what maybe I had said first, but then when they saw it themselves, they were able to really see, okay, that's what you meant. And having teachers watch themselves teach is a very widely acceptable approach. So this is the checklist, and we included concepts from learning climate, so introducing yourself, asking your learner's name, waiting 5 to 10 seconds, using supportive phrases, and we gave examples of supportive phrases. Goals, developing goals and relevance was included. Questioning as a teaching tool, so using open-ended questions, and then the different types of questions that you can use. So recall questions are ones that we commonly will ask, what is jaundice? And that's an easy go-to, and that assesses knowledge, but it doesn't assess higher level thinking. So when you're diagnosing your learner, a recall question is great to use to figure out, do they know the content, but can they actually comprehend, or can they apply it to a twist in a new situation? And then you want to summarize at the end, and from my perspective, from a learning climate, being someone who's very focused on being on time, and when people run over, is to make sure that you end your session on time. It was meant to be a 1-hour session. Students have places to go, they have to be back on the floors, they have to go study, to not run for an hour and a half, to really make sure that if you have an hour to teach someone, that you're using your time over the course of the hour. So Becky Blankenberg, when she reviewed this, she was my project mentor externally, suggested that it was the equivalent of a structured clinical observation form. She's like, this is a structured clinical, why don't we call it a structured teaching observation form? I said that was brilliant. And many thanks to Rena and Rainier, who also met with me to review and give feedback. And so the things we incorporated were giving examples of supportive phrases. On the flip side of the checklist was examples of the different types of questions, because certainly when I first started creating this, the recall question is easy, but application analysis, which is again the higher level of guess what I'm thinking questions, we gave some examples of what that meant, or how you could structure that, or how they were worded. And we added the rarely and frequently options to get a sense as to, were students really, or were the residents really just going after the recall questions, for example, and just doing a limited number of application or analysis. So the PGY3 residents were videotaped while teaching the jaundice case, which was an hour. They were given a faculty guide with the questions and the content, but they were told it was not prescriptive of structure, so they could do it however they wanted to do it. They completed it at least twice, and it was not part of the students' grade, which was helpful because we didn't focus on the students, but we were obviously videotaping the students talking. The checklist was completed as a self-assessment immediately following. It was completed as they reviewed their own for the first phase, and then I, the faculty member, completed it while I watched their video. Then they gave them feedback before they did it again. In phase 1, they completed it in all three. They completed it twice. In phase 2, they did not watch the video review, so they only completed it as a self-assessment. This was IRB exempt, and it was approved by the medical school and student council as well. So just to kind of go through, they would teach the case, and then they would immediately complete the checklist. Then we would separately watch the video and then complete the checklist. And then we would meet usually right before the session to give feedback, and then they would teach again. They would complete a self-assessment, and I would watch it again and complete. Just for the purposes of analysis, we transformed that into a numerical score. And so the total possible score was 22, and we compared the differences by t-test. So for the first phase, which we called the intervention group, and I'll explain this in a minute, they completed, there was 14 residents completed at least 2 sessions. So for phase 2, which we then kind of called the control group, the residents did all except they didn't review their own video. And there were 11 in phase 2, and then I was the only faculty member who watched the video. Why did we do a control group? This was not designed with a control group in mind. We didn't do this as a control. It was, I would meet with the residents to explain what was going on, and I would tell them they were going to get videotaped and watch themselves on video, and then grow and be like, oh my gosh, don't make me watch myself on video. And then I'd meet with them to give them feedback, and they're like, oh, I hated watching myself on video. It was so weird to watch myself on video. Was it valuable? Yes, but I hated it. Okay, so I wondered, all right, maybe then they don't need it. Like maybe all we need to do is to have them do it, get the feedback, and do it again. And they don't actually have to go through the painful process of watching themselves on video. So for the first phase where they watched themselves on video, they did improve their scores between the first and second session. Learning climate was very easy. You know, they consistently established a positive learning climate, and that was similar between the sessions. And this is the faculty review scores improved. 100% of the residents in the first session used a recall question. Recall questions are very easy to go to, and you really don't need to practice them to do them, but the higher level questioning actually does. How do you ask a guess what I'm thinking question without making it totally guess what I'm thinking when they have no idea what you're actually asking? And so between the first and the second session, the variety of questions that the residents asked increased. And when I would meet with them, I'd say it's not that you have to ask all these questions at least 3 times over the course of the session. You may have a student where you can't do that. You're assessing their knowledge by the recall questions, and you're actually recognizing that they have major knowledge gaps that you're having to fill. But if you ask those recall questions and they're nailing it, then you can really move up the level of asking those higher level questions so you can get a sense of where they are, but then also teach around it. In terms of self-assessment, their scores also improved between the first and the second teaching session. And the scope of this wasn't to compare all the different types of assessment, and so I don't show it, but their video review scores were similar to their self-assessment scores. I always think it's interesting, how does self-assessment correlate with, or how is it different to how the external assessor is measuring it? And so it was interesting to find was that for the first session, they scored themselves much higher than I had while they were assessing themselves, but by the second session, they were similar. And hard to know whether or not their self-assessment skills improved after using the checklist, or whether or not their skills increased and then they were the same, but it certainly was interesting that, that our assessments matched. So to review, once we completed phase 1, and I did it at the end of an academic year, and then really realized that they hated it, and maybe they don't need to watch themselves, we started the control group, where really I was the only one that watched the video. And just a reminder again, this is the different components of the checklist. So at the beginning of phase 2, we compared the STO scores, or not beginning. So for phase 1 and 2, so phase 1 being the intervention and phase 2 being the control, there was no difference in the first session scores. So they performed similarly on the checklist for their first session. Both groups had improvement in their scores. So for the control group who didn't watch their own video, their scores improved. In part probably because they taught and they taught again, and they got comfortable using those skills. And then the intervention group as well. As you can see here, the scores between the control group and the intervention group for the second session are different, and statistically significantly different. So residents who watched their own teaching session had a larger increase in skills as measured by the mean STO score. And this was anecdotally, I didn't do statistical analysis because there wasn't that many subjects, but just kind of looking at it, it was the questioning as a teaching tool, using those higher level questions but also stating goals, relevance, and summarizing at the end were very, very easy skills that they didn't think of to do in the first session, but in the second session, they absolutely were they started the session by framing the goals, the relevance, and then making sure that they did the takeaway points at the end. So in terms of reflective critique, as we like to call it in educational scholarship, this was not designed or intended to be randomized or controlled. I was the one faculty reviewer, and I wasn't blinded to the quote-unquote intervention. I did watch the second video. I will admit, I always watched the first video before their second session because I had to give feedback. But then in terms of watching the second video, I just didn't have the time in terms of prioritizing that. So that got done later. So in many cases, it was actually a number of months later that I was able to watch the second video. Our checklist was one that we created on our own. I actually wondered, particularly at the bedside, that the checklist might be more usable as a done or not done instead of trying to have it as frequently or rarely, in part because in an hour-long session, it was certainly easy to get those numbers of questions in. But if you're teaching at the bedside and you're just wanting to see if people are able to use a number of different levels of questions, that maybe they might not have to do it frequently. And I think the residents also felt like they had to do it frequently because it was in that rarely or frequently done. So I always, when I introduced the form to them, I said, you don't have to. But characterizing the higher level questions was a challenge. So the difference between the synthesis analysis questions, or sometimes there's certainly a gray area. And we are hopefully getting the statistical support to complete, to look at the reliability and validity. So the residence teacher literature has limited objective outcomes that can be translated to assess in real time, which is why we developed this checklist. And I really wonder, when you talk about the literature, you say, oh, there's these gaps in the literature, you have these interventions and they're not randomized, there's bias, there's this, but maybe the intervention should just be that they're teaching and they're getting the feedback. And they're teaching in a variety of different settings and practicing and getting the feedback on their teaching and teaching again, as opposed to designing an intervention that's a residence teacher curriculum and using that intervention. Well, but everyone should be getting that curriculum. And then I think figuring out in terms of skill acquisition, it's what do we need to do? What sort of settings do we need to have them in? Does it need to be a number of different settings, or can we just have them in a simple setting and then they can translate it into other settings? And certainly a validated STO could provide the structure for feedback to teach in real time, whether that's at the bedside or a structured setting. So residence teacher curricula are widespread, but there are certainly gaps in the literature. Reproducibility is certainly hard, and objectivity. Many of the studies focus on developing this, how do we have an outstanding, are they excellent, are they superb, or are they mediocre? Certainly use of a structured teaching observation tool can objectively assess teaching skills, and residents who watch their own teaching appear to have enhanced skill acquisition. And hopefully we will look to measure the reliability and validity. So in terms of acknowledgements, thank you to Rena and Rainier for feedback. I think just in terms of, the IME here, there's such great resources. So obviously Rena as a resource, but then I presented this at an IME brown bag lunch. For those of you that have any works in progress or developing things, certainly take advantage of the brown bag lunch. I got really great feedback on this during that. And then this project was a part of my participation in the Academic Pediatric Association Educational Scholars Program, which is this really phenomenal program that was a 3-year faculty development program that was a combination of in-person learning at a national meeting, but then also monthly webinars. I received this certificate of excellence in educational scholarship, but the networking was incredible. So my ESP mentor, Becky Blankenberg, has not only provided great feedback on this project, but has gotten me linked into a number of national projects and publications and workshops. And I was very grateful that Dr. Satlin, my chair, not only provided the funding for participation, but also 10% protected FTE to participate. Thank you. Any questions?